In this video, I'll demonstrate how to insert a MILA pneumothorax catheter. We'll use this cadaver I've pictured here in a whole body view for your orientation. As in the live patient, we'll do a sterile prep and cover with a fenestrated drape and center the drape over the position of interest, typically at the 7th or 8th intercostal space. I'll confirm that by palpation of the last rib and walk my fingers up from the 12th to the 8th intercostal space. In this close-up view, I'll reconfirm my position and then block the entire chest wall with 2% lidocaine, injecting into the skin, subcutaneous tissue, intercostal muscle, and pleural space itself. Confirm that location by aspiration of air in the case of pneumothorax, and then gently scratch an X in the skin at the location I blocked so I can find it when I come back with my instruments. This is an open kit, for example, and it's got two sizes of insertion catheters, the green and the larger orange, a guide wire, the catheter itself, and a variety of holding devices that will apply to the catheter after it's positioned. And there's also a one-way injection valve that will permit aspiration with a syringe but won't allow air to be aspirated into the chest cavity. Next, I'll do a stab incision with a number 11 Bard-Parker blade at the site where I've previously blocked the skin. The blade is held upside down and just pokes straight in and is pulled straight out of the base of a tent I've created with my other hand. This wound needs to be just large enough for the catheter to pass through and no larger. Now I'll use the smaller of the two insertion catheters, the 18 gauge, insert it through the skin incision, and while aspirating on a syringe to confirm placement into the pneumothorax, advance it over the cranial edge of the rib in front of the catheter. Once I confirm hitting air, I'll pass the catheter off the needle. It doesn't travel very far, as you can see. And while holding my thumb on that, take the guide wire, retract it into the insertion device, release my thumb, and slide the guide wire through the catheter into the pleural space. You don't need to put very much of this guide wire into the pleural space. In fact, you need enough left out of the chest that it accommodates the full pneumothorax catheter. So I held the catheter, or the guide wire, in place and withdrew the catheter off of it. Now I'm taking the pneumothorax catheter and threading it over the guide wire. And at this point you need to make sure that some of the guide wire is sticking out of the far end of the catheter at the Luer adapter so that you can pull this out after the catheter has been placed. Now, while I'm twisting and pushing, insert this down the track created by the 18 gauge catheter into the pleural space, and I'm aiming it relatively parallel to the spine and advancing it into the anterior chest. Once it's positioned, I pull out the guide wire and cover the Luer adapter. I'll now place on the one-way valve and securely lock that in place. The catheter can either be sutured in place at this location, or if it needs to be partially retracted to fit properly in the chest, withdraw it back to the desired level and then put one of the catheter anchor adapters around the catheter by bending it backwards to open the channel a bit. Press the catheter within and adjust that to the desired depth. Now I can cover this with a snap-on cap that firmly cinches the rubber adapter to the catheter to prevent it from sliding, and this can be sutured in place. I'll take double-aught monofilament nylon and go through skin and the eyelet on either side. I've secured the lock and the base of the catheter itself. And I'm testing that it's still patent by confirming that I'm able to aspirate air from the chest. An alternative way to secure this is to not use the plastic cap that cinches down on this guard, but rather use cerclage sutures around it. If that is used, then you have to place a loop of suture through the skin and tie a secure knot around a loose, not tight, ligature in the skin only. Then take the two ends of that suture, put a surgeon's throw in it, and cinch hard on the blue catheter collar. You do not want to have a single suture around skin and this device. You'll never be able to get it tight enough without strangulating the skin. And this is repeated at the distal suture collar. One final trick to snug this up against the skin is to pass a suture near the point of insertion through the skin, underneath the catheter, and then take the long ends around the eyelets for this catheter anchor and bring the skin up to the anchor with the appropriate tension and tie a square knot at that location. This covers the exposed area of the skin wound by snugging it up against the blue catheter anchor.